Good afternoon, and welcome back to our final session of the Maine Public Health Association's 2022 annual meeting. Our final session is called Arguments for and Against Universal Healthcare in Maine. My name is Becca Bolas, and I'll be moderating today's session. A couple of reminders before I introduce our speakers. The first is that we are offering conference captioning services. Within each session, you will automatically be provided with captioning, which will appear beneath the video stream. You can click the link to access it in a separate window if you prefer. And if you don't need the service, you can push the pause stop button and it will stop the stream. The second reminder is to please be sure to complete the session evaluation. It's just 4 short questions and your feedback is very helpful to us. It is required to complete that if you're seeking continuing education credits. You can find the evaluation in the session description, and I'll add it to the link. I'll add a link to it in the chat momentarily. So with that, I'm excited to introduce our session moderator, Tom Stern from Maine All Care, and then Tom will introduce our panelists. So I'll turn it over to you now, Tom.
Thank you, Becca. Good day, and thank you, MPHA, for inviting us to participate in this important set of meetings. I'm pleased to introduce to you today the 2 panelists here to provide both an overview and a set of possible solutions to what we hope we can agree is a major crisis in both the delivery and the financing of personal and public health care in the United States. Dr. Hank Gurhis is an emergency medical physician with 30 years of experience. He has an interest in healthcare financing and reform. He is a past president and current vice chair of Maine All Care. Dr. Jeff Gratwick is a retired rheumatologist from Bangor and served in the state Senate for 8 years, where he chaired several health-related committees. He was a board member of Maine All Care and is a current board member of the Maine Public Health Association. My name is Tom Stern. I'm a retired primary care physician and economist. I moved to Maine from Massachusetts 6 years ago after years as a community health center leader and practitioner. My interests include healthcare financing, policy, and healthcare disparities. I serve on Maine All Care's board as its recording secretary, and I will serve as moderator during this presentation. My hope is that you will come away from this discussion with a better understanding of these critical points. Number 1, that despite being the healthiest country in the world, wealthiest, we do quite poorly in terms of major health markers compared to 20 other industrialized nations. And yet we spend more money on healthcare per capita by nearly an order of magnitude. Number 2, that this outcome has been conditioned by a system of financing that has resulted in exorbitant prices for both direct care and medications, and a high percentage of resources consumed by administrative overhead. Number 3, that the current system delivers care in a skewed manner, resulting in vast disparities of utilizations and outcomes. And finally, number 4, that a system that pays publicly or centrally funded can, as in other countries, result in broader and more fair coverage and controlled expense. I hope my 2 panelists will take up the point from here, and I will now turn you over to Dr. Hank Gurhis.
Thank you again to the MPHA for allowing us to speak. It was an honor listening and enjoyable and educational to listen to the previous speakers over the last several days. And many people have shared wonderful visions and also vented frustrations. And hopefully we can help you with some of those frustrations and some of those visions as time goes on. As none of us have any specific financial disclosures, again, all of us are on the board of Maine All Care, which is the PNHP, or the Physicians for National Health Program chapter for the state of Maine. So how and why? Why does public health and universal health care in any entity, such as a state or on a nation, work together? So imagine with me a universal, publicly financed, privately delivered healthcare system, federal preferred, but state if needed. I'd also direct you to the APHA policy statement from October of 21, adopting a single payer healthcare system, and just some quotes, which I think they get it right. Achieving universal healthcare coverage for all US residents requires significant system-wide changes in the financing of healthcare. And the best, most efficient and equitable healthcare system is a public single-payer system. I'd refer you to that document for their further discussions about how they think public health would be advanced in the United States with a single-payer healthcare system. So the current paradigm or rubric in the United States is seeking value in healthcare. Current framing of value could be cost versus quality. So what value does public health bring? I mean, it's hardly mentioned, but there's the classics: clean water, oh my; sewer, oh my; immunizations, oh my; and of course, anti-tobacco, right? One of the greatest public health successes, other than water and sewer and immunizations, over the last 50 years. And believe me, you people know what a struggle that was. So value in healthcare. So I'm going to call this slide 1, because in a sense, it sends the idea of what? I mean, many of you have seen this before, and there's nothing that you don't easily understand, but there's a question of cost versus quality. So how come other people live 3 to 5 years longer than we do and do it for a third less? You know, the kind of rubric is every system is perfectly designed to achieve the results it does. So the question is, what's wrong with your system? And that's what we will explore. So which is the outlier? Of course, we're always looking for outliers and trying to push them back into not being outliers anymore. So if I was trying to sell you pillows, and I was going to sell you a pillow that was 5% less comfortable, but cost a third more, would you buy that pillow? I mean, I don't know. I can sell pillows online. In other words, would you enact legislation if you were a de novo country? Would you enact legislation that gave you this results? And the question is, well, why do you have legislation, public policy on the books that gives you these results? What's wrong with the outlier here anyway? Well, there are 4 general principles used to obtain universality and cost effectiveness by those non-outlier countries. The first one is one payer. Now, there will be modifications and differences between the various entities, various other nation states, but in these 4 principles are pretty much for all. One payer that pays providers of care directly, with no subcontracting of funding to competing risk-bearing entities, i.e. there's no complexity with financial rent-seeking middlemen. We'll define rent-seeking later. There are, number 2, there are budgets for institutional providers of care, including hospitals, nursing homes, community health centers, etc. Number 3, there's a simplified and standardized fee schedule for individual and, for the most part, independent. Fee-for-service is a predominant model in most European countries for general practitioners. Independent providers. And of course, negotiated for pharmaceuticals and other medical devices, pretty much used on a reference pricing type scale. So questions on those 4 we can entertain later. But for later self-study, I'd recommend that you go to the Commonwealth Fund, which produces about every 2 years a comparison of OECD countries. Wonderful sort of wonkish thing if you want to read. I would direct you, instead of reading for 30 to 40 countries, I would go to the ones with most up-to-date healthcare systems, both developed in the 90s. It would be Taiwan and Israel. I would refer you to read those first before you read all the other 30 nations. Some basics in public health, in population health. This is stuff you know, but I'm going to ask you, how will you accommodate these things or account for these things in your healthcare system? Okay, so there's a lot of things called 20/80 rules, right? And in a sense, I'm a clinician, so I only have to deal with the 20% because I do acute healthcare. So if there's something wrong with the system, hey, I only got 20%. It's the other 80%, which to me looks like public health stuff. So it's like, are these other countries doing these things better? Is this all of our difference in healthcare and spending just public health? Or are you people, the public health system, getting something wrong here? Don't blame me. I only got 20%. You got 80% of the burden to explain. How's that? I don't want to be unfair, but okay, I'll put that out there. You can laugh at me or yell at me later. No problem. Another 20/80% rule is that 20% of the population generates 80% of the expenditures. Or in other words, 80% of the people have to pay for the other 20%. This is a predictable, inevitable, and unavoidable. It's a question of human anatomy and human society. It may be an unfortunate truth, this sort of 20/80 rule, but it begs the question, how do you organize a healthcare system based on these sort of concrete sort of things that just will not go away. Well, when do you come from a net giver to a net taker for the financing of healthcare? And I'd say it looks like it starts at age 58, which means why that? Well, that's because illnesses start sticking to you and you can't shake them as much. Again, it's natural human physiology. Here's something from Canadian Institute of Health Information, and they graphed taxes paid or the premium, the public premium you pay for the healthcare system, and when do you end up being a net giver to a net taker in healthcare? Again, it would be nice if we could move this from 58 up to 62 or 65 or something like that, but that seems to be the current state of human physiology in healthcare, at least in Canada. Another question comes is there's been a paradigm about high deductible health plans. And I don't know how you can view those unless you look at the quintiles of income. Now, I like this graph because even though it's 2011 CBO data, it's nice and colorful and simple and stuff like this. It actually, the numbers look pretty accurate for Maine now. But just think about this. The lowest quintile, in other words, there's 250,000 people in the state of Maine who earn on an average, a median of $24,000 a year. Design for me a healthcare system that works for them. Okay. Well, there is a paradigm that everybody needs to be financially involved with their healthcare expenditures or their illness. That is part of the sort of value-seeking managed care rubric that came up for the last 40 years we've been dealing with. So the lowest quintile, okay, we can put them on Medicaid or Medicare. There's elderly old and there's non-elderly poor. Okay, how about the second quintile? Well, some of those people will be on Medicare and Medicaid, but some of them are going to be probably now, at least, in the ACA, getting heavily subsidized premiums, but they're still going to have high deductible health plans. The middle and the fourth quintiles are going to have private insurance as well as some ACA type plans, but they're still going to be stuck with the high deductible health plans. In other words, they're going to be financially involved with their illness. Now, the highest quintile can probably negotiate this at a better rate. They will also have high deductible health plans, but obviously with the income disparities we have in this country, how do you do that? So seeking value in healthcare. The current US paradigm is managing costs through applying fiscal risks to the purchaser, the provider, and the individual, the patients. And these financial risks are applied or managed through third-party administrators, otherwise called health insurance companies. I'm not sure if when I dropped the term third party, you're just a third party administrator on a health executive. They said, no, we're not. I said, well, you just process funds. You're not taking insurance risk anywhere. You always push it off anyway. Well, that's a different thing. So let's just say that, but the idea is you manage costs by applying it to the people who will feel it acutely. So the value paradigm started back in the 1980s. Remember the term managed care organizations, or MCOs. Everybody hated them because they had the drive-through deliveries, right? You have your baby and out the door and you get grandma out of the hospital as soon as possible. Well, it's had various names, and I would say it's a failed paradigm. HMOs, high deductible health plans, value-based purchasing, the VPPs, accountable care organizations, the names change, but the financial rubric is about the same. MACRA MIPS is probably more of a provider thing than a public health entity, but the current rebrand direct contracting entities, or the REACH program, I can't remember, is coming down the road over there. The question is, has the outlier found value? And I'd say no. The outlier country still has not been able to find value in its healthcare system besides a value paradigm of applying the costs and the fiscal risks directly to the patients or the physicians. Again, promise versus practice. What about all this value stuff they talk about? Well, there's mixed results. This is a very deep dive and full of imperceptible reading for me. But basically the accountable care organization movement, moderated through CMS, the pioneers, the MSPs, the next generations, et cetera, et cetera. The savings are, if they're there, they're minuscule. They're in the 10th percentile. And are the findings real or not? This may not even account for the fact that CMS needs to monitor these people, and that anyway. So instead of minuscule 0.1% savings in this value paradigm, I can give you a paradigm that will save you 10 to 30% off the top. I just need to do a complete system redesign. Seeking value in healthcare, managing whom? The current US model is to fiscally manage patients and providers. The rest of the world, manages the fiscal intermediaries. That's because the government either is the fiscal intermediary and can manage themselves, or all the other sickness funds or all the other sort of pseudo, what you might want to call in fiscal intermediaries, insurance companies, Europe, are basically these highly regulated, non-profit entities that pay their CEOs $200,000 a year and not $20 million a year. So the model is entirely different. However, there is some value in healthcare, and that's stockholder value. Okay, basically, you're going to hear the argument: public funding in healthcare is bad. Government is bad. Well, I don't know. Everybody wants public funding, especially the rent-seeking entities. And I defined rent-seeking in this regard as rent-seeking in healthcare is private entities engaging in or involving the manipulation of public policy, public money, or economic conditions as a strategy for increasing profits. So the Kaiser Family Foundation, from a report they probably came about 2 months ago, looked at the gross profit margins of the various healthcare insurance products. The lowest, of course, is the group market, because their insurance companies are negotiating with hard-nosed business people and getting a lower rate. But look at that. The greatest margin comes from Medicare Advantage, which is a federally funded public money. Medicaid managed care is a state and federal public money. And the individual market, I think 60 to 80% of the individual market is now ACA plans. And I think 80% of those premiums are paid by who? The federal government. So if there's already tons and tons of federal money in our healthcare system, let's go for this. Let's just admit it, and let's go for the much more simplified plan that doesn't have rent-seeking activities, therefore engaged. Seeking value in healthcare. So how might a state-based system look like? So let's say if a state wanted to go on its own and achieve a healthcare plan. Well, you always wonder about a small state, but Nova Scotia and New Brunswick seem to be able to do it. Iceland has 600,000, and those Canadian provinces have about 1 million people in it, like Maine does. Iceland has 600,000, and they're able to do it. So basically, a state plan could not, by various ERISA and federal, would not be able to displace, shall we say, or outlaw other insurance products. But the state would become a major pipeline state, because it would be a very large healthcare insurance product, processing the majority of healthcare funds in a state with resultant administrative simplicity. So that's goal number one. Paying a single rate structure throughout as an attempt to mimic global budgeting, because again, healthcare is a known statistical quantity. There will be so many heart attacks, so many appendicitis, so many, et cetera, so you can budget that with a singles rate structure and a simple payment schedule for providers and physicians and hospitals. And hopefully the state would be able to negotiate RX pricing. This comes from a study that I'll talk about a little bit later. So what would the basic design by category of population? The top color graph is the current, where about half the population is in employer-sponsored plans. Medicare has its 30 to 40%, Medicaid 30%, and the healthcare gov and the uninsured. The new healthcare plan would be basically the state would provide, again, a health insurance product. And this would be the, let me get the thumbnails out of the way here. Thank you. Would be a new state plan, basically administered by DHS paying Medicare rates. Now that's what we have a model, and if that works on that, but we can discuss that. The Medicaid would be maximized as much as it can, basically to draw in all the federal dollars that come with Medicaid, S-CHIP, all of the funds that come from the federal government would have to be included or would be maneuvered into the new Medicaid plan. But again, the Medicaid would be paying Medicare rates, so hopefully providers would accept that. Medicare, of course, can't be touched, and nor the VA, the other federal plans. But the state health plan may be able to either start its own Medicaid Advantage plan or be wraparound for the Medicare and provide the Medicare plan that way. Part of a study that we did, Maine All Care did in 2019 from 2017 data, is the healthcare budget in the state of Maine was about $14 billion back in 2017, sorry. And our analysis showed that we could save $1.5 billion in total healthcare spending, about $1 billion of that by improved administrative simplicity, and the other by a negotiation of price and cost for RX. That study is available on the Maine All Care website, and you'll find it there. And there are copies there of the full study and a 4-page analysis. So who would universal healthcare benefit? Well, we think it would be a fiscal and administrative relief for businesses and employers. So once a year, if your employer provides health insurance, they have to spend 2 or 3 months figuring out, negotiating who's going to be their new carrier and who's going to not raise their rates 12 to 15%, okay, for the coming year. So there's a lot of administrative overhead that has to be used in that. Plus, the average company that pays healthcare premiums pays about 12 to 14% on top of payroll to pay for those premiums. Our study indicates we should be able to do that for anywhere between 5 and 10%, depending upon the size and complexity of your business. So one, we would provide you fiscal relief and also administrative relief. In other words, freeing you up to be the business you wanted to be. Number 2, employee rights. Well, the first thing that will go away is a job lock. All of us, many of us are locked into jobs because of healthcare. That would go away. Plus, if you're an employee, you negotiate for 4 things now: pay, working conditions, retirement, and healthcare. If the healthcare went away, you'd only have to negotiate for 3 different items now in healthcare. And I think that would improve the employee situation in those negotiations. If you look at cities, states, and towns as businesses, again, they are relieved from the administrative headache of negotiating a new plan. Plus, we think we can save them some money. And just think, if cities and towns could now go, instead of concentrating on about 1/3 of their budget, which is healthcare, they could now just concentrate on education and infrastructure, how the education and infrastructure of your town would improve, because that's the only 2 things they need to really consider. Healthcare provider, a lot of burnout in healthcare providers is the complexity of the paperwork and the grind for finding value, in the services we provide. I think anybody who wants to do population QI studies, would know if everybody's in the data pool, you can do a lot better population studies. And we think it would provide fiscal stability for healthcare facilities, particularly rural facilities and rural providers, and also for the entire system. The question is, what would it do for public health? Do you think that public health as an entity, as a thought pattern, as a paradigm would improve in a universal healthcare system? Well, you could become a bigger voice, because suddenly community health is now seen as a cost driver. Oh my goodness, we have to give people COVID immunizations, not because it saves lives, no, but because it saves money, right? So way to go, public health. Save us some money by getting people COVID immunizations, please. Would you get better funding? Well, I don't know. I don't know that, but now you'd be able to negotiate with the state insurance entity for your plans. Maybe you'd like that better or not. How does public health compare in Europe? They are not held back by this healthcare funding issue. Many of the presenters over the last 3 days have talked about the fact that if they could get past the healthcare illness issue burden, then they can move forward in other areas. I mean, frankly, I don't think public health in Europe is constipated, shall I use a medical term, by the healthcare funding system of illness. And also, I think public health would better be seen as an entity better valued on its own, because now you're a bigger player, because everybody recognizes that 80% of the healthcare bill. Oh my God, we have to start dealing with that 80% of the healthcare bill. Maybe you can actually get a high fructose corn syrup tax if you really want something like that. Okay, well, that's it. Thank you. My questions again for you is, has anyone ever been in the public health system in Europe, and do they understand, and can they view that, explain that, how that might be better? And has anyone been in Taiwan or Israel to help understand how those societies manage their healthcare issues? And I'd say thank you very much. And Jeff, I'll hand the program over to Jeff.
Hank, thank you very much. Jeff Gradwick, please move in.
Just want to be sure that everybody can hear me. Can you hear me adequately?
Yes.
Yes.
So thanks to Maine Public Health Association, to Becca, to Tom, and to Hank for starting this off. It just is often speaks in a monotone, dispassionately when you're on grand rounds, you're at the bedside, because you don't want to get all excited. Having said, and I sometimes talk like a monotone, but having said that, this is a topic it's going to get, which gets me excited. We can't talk about them any longer because our healthcare, the patient. Background, I think the Maine All Care, I recommend you not only look up Taiwan and Maine All Care.
Jeff, I'm sorry. Can you hold on one second? Seems it's a little choppy. I wonder if you stop your video stream, if that will help.
Okay, I went to a special place in my, it was supposed to be better. But I don't. Oh,
And if that doesn't work, we have a call in you can use.
Push, side by side gallery, exit. I'm afraid if I exit full screen, I'll exit my slides. So, okay, thank you very much. Now, please, Becca, raise your hand or just wave at me if you cannot hear me easily.
This sounds good, Jeff.
Okay, thank you.
Thank you.
A plug for the healthcare systems, Israel, Taiwan, and then Maine All Care, a good website. We invite people to find out about it. Group of both business people, physicians, regular citizens working to have a better healthcare system here for Maine. My first slide, the overview, universal healthcare makes medical sense. Our cultural and the enormous power of the moneyed interests supporting this status to size. It will save lives. It gives better care for more people. Use money. You're going to have to put money into it. And people's income is going to be positive. You're going to have more money in your pocketbook, and the major obstacles are the political ones, particularly gridlock, particularly groups trying to score points on one political group versus another. There are cultural biases. None of us seem to like change a great deal, and it takes in our current, and we have to overcome that. But then, as Hank has just said, moneyed interests really have bought the system, and we now have a system that allows the rich to get richer, and it's really not benefiting us all. Next slide, please.
Jeff, we're going to pause just one moment. We hear you great, and then it goes out, and we hear you great, and it goes out. And I wonder if it may be better to have you call in. Is that a possibility?
Yes, I have a cell phone here. I can do it. Shucks, I'm very sad that this is happening. What numbers do you want me to call in?
Let's see here.
So, well, please wave your hand if you can't hear me now, but I'm talking on my cell phone. So, initial slide overview, and then talking specifically about the failures of our current healthcare system in here in Maine. Some of this is really a different way of looking at what Hank has already talked about. It costs too much, and we have poor value for money spent. And the figure is anywhere from 19 to 22% of Maine's gross economic product goes for healthcare, as opposed to roughly 18% for the US average versus 10 to 12% for the European Union, for Canada. And as I said, we're spending a third more, and we're on the tail end. Our healthcare of our population is not as good as our peer groups. Insurance companies make the decisions to benefit stockholders, not for patients. Insurance companies are businesses, and their primary thing is rewarding Wall Street, not taking care of patients. There's an enormous amount of waste that we've already talked about somewhat. The overhead of our system here in Maine is anywhere from 20 to 30%, depending how you calculate it. Some insurance companies say that the very high salaries of their presidents, their CEOs, 16, 18 million for Cigna. That's a business expense. That's not a waste of overhead. So significant overhead in administrative expenses, salaries, medications we've talked about. But really the thing that gets me primarily is the complexity of our system. It is truly daunting. And I'm sure everybody's had the experience of trying to figure out how you take care of your own healthcare system. And I have practiced medicine for 40 years. I've been in the legislature working on committees. I still need help when it comes to deciphering my own personal medical bills. To the point that insurance company stockholders add nothing to the health of Mainers, and that's why we really need a major paradigm shift. And then finally, the inequitability of this whole system, rural versus urban. Is there a reason that a hardworking logger from Aroostook should have lesser healthcare, or a fisherman from down east, as we've been hearing about, lesser healthcare than someone living in Portland? High versus low income. Is there any difference before God in how we are viewed? Ethnicity, gender, zip code, all those factors are very real, all exacerbated, of course, by COVID. Next slide, please. So, but be sure what we're talking about, and we've gone over this somewhat, but the definition of universal health care is that everybody is covered. It's not always easy. It's easy to say, but not always easy to do. Access, how are we going to give good care to the logger in Aroostook or some mountaineer off in Western Maine? The demand out there may be infinite, but it turns out that in other countries, in Japan, in Taiwan, they actually do very well. People see the doctor more often than they do here in the United States, and they seem to manage that well when everybody is covered. Quality is, of course, a major issue, and the many different ways you can measure that. The one that I think is perhaps most appropriate is avoidable mortality, and that means simply conditions you should not die early from your diabetes, from hypertension, from heart disease. We should have from certain kinds of cancers, from pap smears. We should have a system that allows each of us here in the United States, in Maine, to live as long as possible. The costs of a universal healthcare system should be based on the ability to pay. And we need to have, as we've had in the past, better progressive taxation than we do now. We should also have progressive financing of healthcare, which is to say, if you're in that lower quintile, you should be paying a small amount of dollar values. If you're in the very high, you can spend a much higher dollar value contributing to the well-being of all. We don't seem to object to paying for police, fire, public education, airline safety, and The same should be true with healthcare. As talked about before, this should be publicly and not privately controlled. A public entity, public-private entity is certainly a way to get a better balance. But there's input from everybody, not just input from the insurance company boardroom. And my perspective here on is that the morality of a universal healthcare, which is to say we're all in this together in life, and self-interest, which is say you're a very rich person, you want to keep all your money for yourself, you want to live in a gated community, but you still depend on people to farm in the fields, to fish, to take care of your roads, to the police, fire. We're all in this together. It makes sense for everybody. Thank you. Next slide. Are you hearing me okay now? Good, thank you. So what a healthcare system could look like in Maine. And it would be basically, we've already talked about equitable. Everybody's in. When you go to the doctor, you don't worry about what insurance form you have. You are covered, exclamation mark, period, end of sentence. Second, controlled by our nonprofit quasi-state agency. There are many different groups like this in Maine that do a very good job. They're underappreciated, but the Maine Turnpike Authority, we all see in its daily actions, Efficiency Maine, and there are other groups, often with a limited number of employees, that do a very good job bringing the public and the private sector together. This should be a agency run by technocrats. We do not want it run by politicians. A single payer paying directly to providers, no middlemen has been, we've already talked about this. And it's interesting that Eastern Maine Medical Center here, now Northern Light, has 300 people in its billing office to take care of the folks who come into the system here, whereas in Ontario, with a population of 5 or 6 times more, has 3 people doing exactly the same kind of work. A global budget, we talked about that. The MECEP study is, I think, very persuasive. Negotiated prices for medication and durable equipment. The resistance to that, of course, is someone's profit is going to get diminished. Standardized fee schedules. Then a difficult area, the pass-through of federal Medicare, Medicaid, VA dollars. This may be down the line. It certainly is going to make it much simpler if those monies go through the state agency, but those require waivers. That's probably in the future. Next slide. And how have we reformed healthcare reform so far? And the 2 patterns we have here are, 1, incremental change. And incremental means we've gone about it very, very slowly. And there are, it's just step by step, not pushing too hard against current patterns. And I think everybody's aware the 1960s was a big change in Washington. Medicare, Medicaid, the VA became somewhat more modernized at that time. Changes, but they still didn't get at the issue of profit in the medical care system. The 2008-10, the Obamacare initiatives are again a step, but they're making do with what we have here. The most recent ones, the IRA, the Inflation Reduction Act, certainly has been very beneficial for some. The price of insulin has decreased. 25 expensive medicines are due to decrease, but not until 2026. And really, this is not incremental change. This is micro incremental change. But at least it's moving in the right direction. There are other attempts in Washington to be a little more dramatic. Attempt at Medicare for all, a very interesting reading, and that political future is uncertain of that. Here in Maine, we've had incremental changes that have been good, no question about it, but they still don't get at the major problems of Medicaid expansion. the first day of Governor Mills's term, drugs for the elderly, the CHIP program. These are local, but have started out federally. The transparency of hospital charges makes a great deal of sense, but it's been very it's slow to get it going. And low-income dental, and there are other things where we're making these changes. But as I note here, these incremental steps have not changed the basic profit orientation of our healthcare system. Next, please. So the next is to take, what would it be like to have a quantum leap, to really change, as Hank was saying, to have a radical change. There have been multiple attempts to do this in Maine since the 1980s. They've not succeeded. And the one I was familiar with would start off in 2002. I was in the legislature for 8 years. And there were a number of different ones there. I worked hard on something called LD, Legislative Document Number 52, that it was incremental in its sense, but it would have taken 10 years, and we would have then had a universal health care for Maine. It was sort of taking the practical reality of getting things working over time. Currently, there's other legislation that would allow the establishment of a public-private organizing group if appropriate changes occur in Washington. I think it should be emphasized that the role of the legislature is going to be pivotal here, and this is where the political process, where contacting your legislators is going to be very important, because the governor can propose, but it's the legislature that disposes of it, and the legislature is not going to act unless we, the people, really push them. There obviously have been many initiatives in other states, Vermont, California, Colorado, New York, and more. And I think over the next couple of years, we'll be seeing some changes there that are appropriate. Next. Getting towards the end, why universal healthcare would be good for public health. Public health would become a priority and have a seat at the table, as seen on Hank's diagram, the 80-20 rule. If you can prevent illness, you're saving money, you're saving lives. Prevention is much less expensive than cure. Prevention saves lives, it saves money, it saves workers, it saves our economy. And the usual suspects, we can deal with these. We know how, if we have enough resources. In this 3 days, you've been hearing about this: smoking, substance abuse, alcohol, obesity, mental illness, and more. But these are things that we can, this is not rocket science. This requires effort, energy, and focus. And then, as said, the focus on the social determinants of health, which is to say clean water, clean air, housing, food, climate change. We should be spending our money on these areas, not on profits for insurance companies, or purveyors of medical devices. Next, please. So my conclusion is just the same as where I started. It makes medical and economic sense to have universal health care. The major obstacles are political, cultural, and the enormous power of moneyed interests. I personally am an optimist. I think we can do it. I think we owe it to our grandchildren. And with that, thank you very much. I'm going to turn it back over to Tom Stern and Beck.
Thanks, Jeff, especially for your heroic efforts at staying and getting and re-getting connected. You actually eventually came through quite clearly. Much appreciated. So I was hired, although I must admit honestly that I concur with the opinions and direction of the panelists, to be a doubting Thomas. So my folks must have named me quite well. What I would like to do before, and if there are any questions from the audience, would be to pose a couple of questions to the two of you that may preempt some of the audience's own concerns. So I'll start by asking, wouldn't there really be overutilization in a system that's essentially free at the time of use? I mean, is that a good thing?
As a practicing clinician, And looking at the data, most other countries have higher utilization rates than we do, particularly in the general practitioner field. It's easier for folks in Europe, Taiwan, Israel to see a GP, which is what they call their primary care providers. They see them more often. And again, those systems seem to demonstrate lower cost. As far as the more expensive type things like hospitalizations, cancer, congestive heart failure, complications of diabetes, those are driven on population-based ways. And I don't think anybody wants to go see their vascular surgeon because of their diabetic complications more often than they want to. The utilization may go up in the primary care community, but that intent is to improve health outcomes and decrease the costs on the more expensive ends.
Thank
Thanks.
you.
My response to that is other countries do seem to utilize doctors much more than we. In Japan, I think it's 3 or 4 times more than we do, but their costs are still less. I think it has to do with the overhead that we have to pay. I was in a 2-person medical office, and we had to have one person. We had 5 staff people, and one of them did nothing but refile insurance claims. And I think that if we were able to have a system where it was more efficient, people could see the doctor, and the cost would be less overall.
Thank you. And the panelists are pointing out that the problem isn't the volume of utilization, but the cost, the price. So that, as we know, price times volume equals cost, and the prices in the United States are indeed quite high. So another question for the two of you, a critical political question. You're proposing that this be centrally funded. Won't people rebel when they see their taxes, or whatever you wish to call them in nice political terms, rising dramatically?
Well, I'm happy to start off with this. Having been in the legislature, realizing that when you talk about, quote, taxes, unquote, it's the third rail of politics, and everybody gets all excited. On the other hand, we pay taxes are the price of civilization. Taxes are the price of having fire, police, airline safety, many reasonable roads, etc. And so I think that we have to be very careful the way we use words. Do we use premiums, and do we actually ask people to calculate in their own head what their taxes would be versus what their premiums are going to be here, and their taxes are going to be here, or their current premiums are way up here and their taxes are going to be more, but still not what their premiums would be. I think people are going to have more money in their pockets, and that should be the deciding factor for it.
Thank you. I would like to ask one more question, and then if there are questions from the audience, I open them up. We've just been through and are still in, I would propose, a significant pandemic. It's affected the entire world. Different countries have coped with it in different ways, these countries representing a variety of different private personal health care models. Where is the guarantee, as opposed to the hope, that a publicly funded system will do better than the general societal response to public health catastrophes in places that have in fact had universal health care on a personal level?
Okay. Hey, you want to start off and I'll finish?
Sure, go ahead, Jeff.
Oh, well, it's simply that we have basically failed the COVID test here in the United States. And the reasons are many. Public health has been eviscerated in the United States over the last 8-10 years. There's not been enough funding. We have not had a good educational outlook. People are not aware of what it means to pay attention to data. We have had vaccination scares, which are, I think, the result of misinformation. And with adequate public health funding, I think we will do much better in the future. We are going to have other pandemics in the future, and this is the warning shot. And I think if we begin to put our money into the public outreach, we'll do much better. I have to say, I think the scientific aspect of this current pandemic has been truly remarkable. There's no question about that. But the public outreach has been very spotty.
Fair enough. At this point, I've received privately questions from the audience from Becca. Becca, would you like to pose the questions, or would you wish me to? Fair enough. So one question that members of the audience had would be the question about what risks would the new system have if federal government leadership was as hostile to the public good as it seems to be right now?
Very good question. The states would have to apply for waivers for the Medicaid spending, the flow of funds. That may exist already under the ACA, depends upon which legal opinion you believe. So I'm not saying a state system or implementation wouldn't be difficult and have some risks. Could a state system be blocked at the get-go? It certainly could. In a sense, you can make an argument that John Roberts, Supreme Court Justice John Roberts, gets to decide all things now because everything will be litigated. So maybe the Supreme Court will stop it in some sort of way. In a sense, this is a political process. And if you take the third rule, right, a third of Americans supported the revolution, a third of the people supported the king, and a third of the people said, just leave me alone, I just want to be a farmer. So the question is a third of the population would say, please do this for us now. This is an insanity and a headache, and we understand it. A third of the population would say, tell me more, I can be taught. And a third of the population would be the real hard sell. It is a political process. It will be fought on by major financial entities, which have a lot of the power. It would be difficult. There is some risk.
And I would simply add there two things. One is that the people who make up the second and third tiers of state government, at least here in Maine, are truly some remarkable public citizens, and they give a lot of, I think, good and forceful feedback to politicians. And politicians here in Maine come and go. You have a maximum of 8 years you can serve if you're reelected, and then you're out and somebody else comes in. So your level of knowledge, after 7.5 years, I finally learned where all the toilets were. I mean, so that it takes a while to get to know the system, but there are very good people there, and I think they would be a guide. They're keeping things on a level, and so hopefully a lot of this government, anti-government rhetoric would back off. Second is we also now we depend on crazies who are making these decisions in insurance company boardrooms. And that's where the decision is. And I think I'd rather have these outliers, these folks, right out in front of us in the committee room hearings, so we can hear them, as opposed to have a hidden diktat coming from elsewhere.
Fair point. That leads to the next question, assuming we have a little bit of time. There's a question that came from the audience about how do you propose strategically overcoming the obvious political and special interests that clearly stand to lose in such a radical change of the coverage and payment system?
Well, there's some political theories that 3% or 10% of the population needs to be. Actually, I heard on NPR the other night that Thomas Ricks, who writes books on military history, actually wrote a great history book on the civil rights movement of the 50s and 60s. So my next assignment for myself is to get that book and read, because again, this is again a political question. And education, time, effort, it sounded have to be a ground roots. Or change in the United States happens because of catastrophes and traumas, and then we have major change. Hard to know. Please help us in our political efforts in this regard.
And my response is very similar. I mean, this is an issue that we all have to take seriously for ourselves, for our pocketbooks, and for our grandkids. I think we have to solve this. It's not fair to push this on, and it will be difficult without question. But we've done difficult things in Maine. We've had the Equal Rights Amendment. We've had voting we've worked on. We're head of the country. And this, if there's any place it can be done, a state with a population of 1.2 million, I think this is where we can show leadership. Will not be easy. And neither the current gubernatorial candidates are particularly in favor of this for different kinds of reasons. But I think that I'm optimistic that in another 2 years we could begin to make progress in this direction.
Becca, do we have time for one more question?
Let's say one more, yeah.
Very good. Thank you so much. So one question that comes up has to do with persons' concerns about individual liberties and freedoms. And they wished a response to the question about whether or not universal health care might impede those freedoms, and offered the example that, for example, could care be denied if a patient refused a vaccine if healthcare were controlled by the government in some way?
I think there's a big differential. The financing of healthcare would be administered. The clinical care, there's always a question that comes up. People want choice. They want to be able to choose their insurance company. Nobody wants to choose their insurance company. Everybody wants to choose their doctor or their hospital. So the question is do immunizations will they be given forcibly? No provider that I've ever worked with is going to say, if you don't want an immunization, okay, go get COVID, and good luck with your family and spread it around. Go ahead, I don't care. Healthcare physicians, providers are trained for patient autonomy. You drive the bus with your own healthcare, not me. I am a consultant. You pay me. You rent my brain to give you the best recommendation or the best thing to help you with your healthcare problem. Nobody's going to force you to get a shot. Now, is there a public health reason for employer or employer-based, or can you get on an airplane, or can you go to Canada? Those are out of my control. But no provider is going to force. If it's publicly financed, we want it to be privately delivered. I want autonomy as a physician. I don't want to have to massage the chart to get a better fee or more money for the entity, for myself or my entity. I just want to take care of patients. I do not see individual freedom in the patient realm as at risk at this at all.
Thank you. Appreciate the assistance of all the technical staff, the obvious contributions of both Drs. Gradwick and Gurhis, and once again, the opportunity to present a particular point of view and exhortation to the Public Health Association.
Yes, thank you.
This was incredible. We've been here for 3 days. We've had fantastic audience engagement over those 3 days. I will say this was the most that I've seen among all of our sessions with all these questions. There's so much. There's still some in here. And I was just chatting with Heather separately. I think we'll have a follow-up town hall about this topic because there seemed to be a lot of really good questions and discussion from this. And it's awesome to see that, our last session of a 3-day conference, and there's just so much engagement. So thank you to the three of you for bringing forward such thought-provoking discussion. And I did just want to share with you there, I know you can't see the audience end of the chat, but I just wanted you to know about 2 comments that were shared. One's from Bill Flagg, which is that savings could fund universal childcare and other critical programs, and the savings would be directed to those types of programs. And then the second comment is from Samantha, and her comment is that she was in Taiwan when COVID hit in 2020, and the community response was very different from the response in the US. And her perspective is that lots of folks responded very calmly, knowing that they had universal health care to rely on. So just a couple of observations from folks in the audience. And I want everyone to know that we do have your questions saved. And so we'll hang on to those and hopefully be able to have these three folks back on for another discussion and even more back and forth. So again, thank you to Tom, Jeff, and Hank for such a great panel and presentation. And thank you to everyone who joined us in this session. Please don't forget to complete the evaluation. We're going to take just a very short break so I can pull up my slides, and I will close you out with some final comments and let you know who the leaderboard winners are and prizes and all those good things. So stay tuned and we'll be right back. All right. Well, I just want to extend, we both want to extend such a sincere appreciation to all of you for joining us for our 2022 annual conference. Thank you so much for being here. This will be a short closeout ceremony with just a few announcements and of course, announcing the leaderboard winners, which I know you're all very anxious about. Before I get there, Those of you that know Heather and me know that we have some very important people and animals in our lives. And we need to share this with you. These are who have been staring at us for the past 3 days while we've been all day on our computers. On the left are my dog Carla in the front, and then my parents' dog Betty in the back, and they are best friends. And then on the right is Heather's dog Gunter and her son Elliot. And we have loved spending the past 3 days with you, and we are looking forward to spending some time this weekend with these others in our lives. So I want to thank our conference supporters, Maine Health for supporting our virtual platform, the New England Public Health Training Center for supporting our plenary sessions, Northern Light Health for being our keynote speaker sponsor, Maine Cancer Foundation for supporting the virtual networking room, and the Maine Health Access Foundation for awarding us funding through its meeting support grants program. A final thank you to our conference exhibitors. It was fantastic to see all of the engagement, especially through the leaderboard and the conference challenges and visiting the booths and getting questions from folks about that. So I just want to thank everyone, all of these organizations that are either members of MPHA and then were able to get a complimentary booth, or folks that financially supported us through a separate exhibitor booth. Thank you. A final thank you to our conference planning committee. So much goes into planning this 3-day conference. It really is, it's so much more even, I feel like, than a one-day event. And just so much thanks and gratitude to all of you for volunteering your time over the past several months. And of course, a special shout out to Heather for all of the back-end support and logistics and the session moderating. There's a lot that goes on behind the scenes that you can't see, although maybe sometimes you could because it would show up in the captioning transcripts, but a lot goes into this. And so I just want to say sincere thanks to the committee and also to Heather for all of their work. Just a few reminders for you all. The first is that if you are looking for continuing education credits, the CME forms are due next Friday, October 21st. And if you have any questions, if you have an issue downloading the form or another question, please email us at that email address. We both can access that. So we'll try to respond to your question promptly. And as a reminder, for the CME credits, you would have needed to attend the session live. But if you're seeking CHES or MCHES credits, you can watch the session in a recorded manner, and that still counts for your credits. Shortly, you'll be receiving an evaluation for the overall conference. I know that we repeatedly reminded you about each session's evaluation, but there is one for the overall conference, and we would really appreciate your feedback, especially as we start to think about programming for next year. Do we stay virtual? Do we go in person? Do we do a hybrid? How do you want this structured? And getting your feedback on that is really, really helpful to us. The evaluation is fairly short, so please just take a few moments and give us your feedback. For those of you who are watching this recorded and those of you that have attended this live, the recordings are available until next April through the platform, so you can hop in and out as you want. And then after that time, they'll be publicly available. So this is available through the site until April 2023. Just a few reminders about some MPHA member opportunities. And if you're not yet a member, please consider joining so you can participate in these and other benefits. The first is that our mentor program applications have opened and they will close on the 14th. I'll say for all of these items, if you have any questions, please reach out to us. We're happy to answer and clarify anything for you. So please consider applying to our mentor program as either a mentee or a mentor. Our board membership committee is issuing a call for participants. This is a great way to be involved in member engagement activities, member recruitment activities, looking at our benefits and program offerings. Same expiration date on the application, November 14th, and you would start your service next January. We have a new public health policy ambassador program, and this is an opportunity for our members to be even more engaged in our advocacy efforts. Everything from researching policies on different public health issues to organizing meetings with legislators, just a range of activities. So if this is of interest to you, get your application in before the 14th and we'll start meeting this December. And then lastly, this coming Monday, October 17th from 9 to 11, we're partnering with Wabanaki Reach to offer a training called Healing Begins with Truth, Understanding Colonization. We do still have some room left, so if you're interested in participating in that, please email Heather. All right, leaderboard winners. We love doing this. So I know that it is frustrating when the answer that you're entering is right, but it's not exactly what we had put in. And so it rejects it. I know there's that frustration, but overall the engagement in this is awesome to see. I'm so glad that folks were visiting the exhibitor booths and sessions and agendas and just learning about all the different activities of the conference. So we both just want to thank you all so much for participating in this and for playing the game. So in third place, we have Erica Ziller, who had 625 points. And second place, we have May Leroux with 650 points. And in first place, we have a 5-way tie, which is just astounding. And all 5 of these people got the max number of points, which is 735. Just incredible. So Jennifer Edwards, Ed Malio, Janet Dosova, Mary Karen, and Corey Powell-Haggerty. All of you will get a follow-up email from me with your prize information so I can figure out how to get it to you. But really just a sincere appreciation to all of you and everybody who played the game, and especially these folks who really went the extra mile, especially this 5-way tie in first place with getting all the points. It's just really awesome. So thank you all very much. We have some water bottles left. These are stainless steel, double-walled, keep hot drinks hot and cold drinks cold, high-quality water bottles. So if you would like one, if you make a $35 donation, you'll receive this engraved Public Health Hero water bottle as a thank you. So please consider doing that. The holidays are coming up, and it's really nice to have a high-quality water bottle and one that supports the association. So please consider donating today and getting your water bottle. Thank you. And my final reminder is that voting is a public health issue. We talked about this earlier this week, and Election Day is coming up in November. The deadline, if you haven't already, to request an absentee ballot is 5 p.m. on Thursday, November 3rd. If you visit 411.org, you can see what issues are on the ballot, where candidates are, check your voting registration, all those different things. So I encourage you to visit that website. Last week, we hosted a webinar with Healthy Democracy, Healthy People, which really does do a deep dive. It's a nonpartisan initiative, but it does do a deep dive into how voting is a public health issue and what are the connections between health outcomes and voting accessibility. You can watch the recording on our YouTube page. And as you heard from Chris in her keynote presentation, we do have a webpage on our website dedicated to information about public health and voting. And then lastly, there's more information about the upcoming election on the Secretary of State's website, which is that first link, and as well as the League of Women Voters website. I will say too, if you're an MPHA member, we do have a list of public health related questions that you can ask at candidate forums. I'll tell you, I've been asking them, and I encourage you to do that as well. One of the issues that we've been talking about is flavored tobacco. Certainly there's a whole host of other issues that we work on, but it's a great opportunity to meet with candidates and talk to them about issues that you care about. So I just want to flag that to our members that we do have that resource available for you. And that is it. So I just want to thank you all so much again for joining us this year at our 38th annual conference. We look forward to seeing you next year for our 39th annual conference. I hope you enjoy the rest of your day and your week, and we hope to see you soon at another MPHA event. So thank you.